Looks like, okay, we're live.
Yes.
All right. Hello, my name's Dustin Anderson. I'm here with Brian Potter today. Brian works as a physician extender at Tigert Orthopedic Clinic. And I'll let Brian sort of just tell what he does there with the orthopedic doctors.
Well, I want to thank Dustin for the opportunity to share a little bit about this setting. One thing I would say, and this is more of a recent, oh, I think I lost the video feed.
No, I just turned my video off so we don't bounce back and forth.
Gotcha. Okay. Well, one thing I would say is that this traditionally has held the term physician extender, and that's something that the NATA is trying to get away from. Physician extender describes a broad classification of individual that assists a physician in any way. So essentially expands the arm or the reach of the physician and the services that they're able to provide. Because that encompasses such a large number of people potentially across a diverse amount of backgrounds and certifications, the NATA felt that it was much more appropriate to refer to ourselves as athletic trainers in a physician practice because it pushes the brand of athletic trainer. You know, we fight constantly for recognition for our level of education and training, and so it's important that we really identify who we are and what we do. So as far as what I do at Tigert Valley Orthopedics, I've been there actually coming up on exactly 4 years. And this really grew out of having developed a relationship with an orthopedic surgeon while working in the traditional setting. And so they utilize me for a wide variety of things in the office. Some skills that may overlap what the physician assistants are doing, some skills that may overlap what a nurse or tech is doing. But that includes anything from rooming a patient, taking their intake vital signs, finding out why they're there, ordering appropriate imaging such as x-rays, if they've already had imaging, compiling those results, doing some clinical exam and history on the patient, and then basically compiling all that to present to the physician. This is why the patient's here. Here's what I've got so far for you. At the conclusion of that, then the physician will come in with me. They'll see the patient while I'm still in the room. And depending on what the treatment plan that they've devised with the patient, they may have me start to carry some of that out, and that may entail home exercise prescription, that may entail bracing, both off the shelf and custom, that may entail casting, splinting, custom splinting with a variety of materials, foot orthotics. So there's a wide array of what they might use me for as part of that plan. In addition to that, I've also been fortunate enough to be able to scrub as a first assistant to the surgeon in the operating room, which has really provided a tremendous amount of education about the procedures to be able to help better educate patients, while they're in our office. So the majority of my time there, that's what I've done. Most recently, within the past 6 weeks, we've had a change in the administrator at our clinic, and due to a resignation, I was asked to fill in as the interim practice administrator. And so for the past 6 weeks, that's where I've been, doing less clinical and handling more of the day-to-day operations of the practice, which is also not a model necessarily unfamiliar to the athletic trainer with our background in administration of healthcare at the secondary school and collegiate levels. And so there are more and more places where the athletic trainer is fulfilling that role at a greater level within the healthcare system, I guess you would say.
Okay. Just to go off what you were saying there, you said you've been working there for 4 years. Would you say it would be a good idea for someone coming out of undergrad to go that route, or would it be more beneficial for them to say, like, do an internship or work for a few years before working in a orthopedic clinic?
Well, I think that really what's helped me the most, especially early on, was the fact that I had several years work experience across secondary school, collegiate setting. as well as having a background in other areas of healthcare with working in emergency medical services, having the opportunity to see different aspects of healthcare that way, maybe that the traditional athletic trainer wouldn't see. So I think all those things have really helped me mesh within the system better. I was very fortunate that the physician assistants, the other allied healthcare staff within our office, were very receptive to me early on, and that, could have gone either way. They could have been very threatened by the presence of somebody else within the healthcare system that they really didn't know what the background or how they would fit. But we've really meshed that together well to create a true team approach to patient care. So I definitely feel that experience somewhere, especially depending on what your role may be in the physician practice. One role that I play is to serve as a liaison to athletic training staffs at 3 different colleges and multiple high schools. So to have understanding of what those folks are needing out of our office really plays a big role in fulfilling that liaison position. There are certainly fellowship routes at various places across the country that many of which are NATA approved now. Oftentimes those folks graduating the fellowship are given preference when you're looking for jobs in a physician practice setting, because they get the experience in the operating room as an assist to the surgeon. They get the experience in how to maximize and improve patient flow and efficiency of the physician. And so I would definitely encourage, at a minimum, work experience, if not pursuing one of those fellowships.
Okay. Going off of the going into surgery and things, our last EAT weekend, we went over some new skills for athletic trainers. One of them was administering IVs, and the other one was suturing. I know you're also an EMT, and you have a unique perspective on both of those. If we'll talk about IVs, if there's any tips or pointers with that one. And when it comes to suturing, how long did it take you to get familiar with that and comfortable with that?
Well, as far as IVs, in the state of West Virginia, I'm credentialed as an EMT, and that's outside our scope, actually. That being said, having been around the system quite a while, an IV is not a difficult skill, as are many of the other skills that people learn in healthcare. It's just a matter of repetitive practice. Very much the same with suturing. It's not necessarily a difficult skill. It just takes time to learn and practice. I certainly think that there is potential value in the athletic trainer having both skills, again, dependent upon the job setting that they would want to ultimately pursue. I think that, professionally, we have tended to stretch ourselves a little bit and continue to add competencies and add things that we want the athletic trainer to learn. And some those are skills that may better fit into the model that folks are discussing, where you would become an entry-level athletic trainer, and then you would kind of pick what setting do you want to go in. Well, if you want to be in the physician practice, yeah, absolutely, suturing needs to then be part of that additional education. If you're going to be functioning in the field at, say, a college university level, where you've got consistent physician presence, a strong set of physician standing orders that support your scope of practice, yeah, having IV as a skill is a good thing for fluid resuscitation following trauma or heat illness. But again, I think to say that every athletic trainer needs both those skills is probably spreading our profession too thin as far as what we're really out there for. Suturing, I don't know that I can really recall a definite time frame. There were some techniques that I picked up the first day that I was in the operating room, such as a simple interrupted suture. As soon as you figure out how to tie, I mean, it's a single pass and you're good. When you start getting into more complicated stuff like closing closing a deeper layer, such as the fascia with figure-8 sutures, or closing skin with, say, like a subcuticular biosin that's going to be absorbed. It's going to be right under the level of the skin, so it's not visible. That's almost more of a plastic surgery type closure, and so something like that takes a little bit more time. Honestly, I did a lot of practice on a dog toy. My dog would tear it up, and I would bring expired suture home from the office, and I would sew it back up together, and that provided great practice. Not necessarily the consistency of skin, but as far as going through the technique and getting the tie down. And it's like any other skill. I was very slow at first. I'm sure if you talk to our OR staff, it just took a long time. Whereas now I feel I'm much better at it. So that when I am over there, it can be more of an asset as far as helping get the physician out of the room a little bit quicker, allows them to prep the next patient, get their paperwork done, enter orders in the computer, all that stuff. So it really helps with the efficiency of their day.
Okay, that's good. Now, have you, I know one of the hot topics with athletic training now is third-party reimbursement. What's your experience been with that, moving to the setting that you're in?
We have been reimbursed for services that I've provided. It's been essentially all incident to reimbursement. So the services provided while the physician's in clinic, but it's not the physician basically doing the hands-on work. And really that happens every day in orthopedic offices everywhere. Before I was in the office, a lot of the casting, and still a lot of our casting to this day, is done by orthopedic techs. And they may have any credential from a certified nursing assistant to having been an exercise physiology graduate. I mean, there's no real standard as to what's required as far as a certification to have that job. The doctors teach them casting, they approve it, and that's who puts the cast on. But the doctor's still billing for that service because their office provided it. So the same holds true if I do a home exercise program for a patient. If they've asked me to fit a brace on a patient, such as a custom ACL, PCL brace, as long as the physician's in clinic, we bill that service incident to the physician. And we've seen, especially on the bracing side, pretty good reimbursement for that stuff. But again, it's not direct third-party reimbursement for my services as an athletic trainer. Hopefully we reach a day where that comes. Other states have gotten to that point. But, specifically for me in West Virginia, I think we're a pretty long ways off from that, with not even having licensure at this point. We're going to need probably to fight that battle before we have more of a leg to stand on with as far as getting credentialed with the insurance carriers to pay directly for our services.
Definitely. What were some of the biggest challenges that you faced crossing over from a traditional setting to a non-traditional setting?
One, and I don't think it ended up being as big a challenge as I thought, but one that I think potentially is a challenge for everybody is really showing what your value is to the other clinicians as well as the doctors. Even our doctor that was heavily involved with sports medicine that I had established a relationship with, we still sort of had to prove that the model could work. I think, getting a stronger understanding of insurance companies and how that process works as far as having services pre-certified or prior authorized, being able to participate in that. Obviously for me, the operating room was foreign. I'd observed some cases as a student, but to actually be scrubbing and involved in that process took a lot of on-the-job training, a lot of just practice over time. There are many skills that we have that fit right in that setting right away. There are other skills like, if you've never cast, that it does take a little bit of time to learn. Although I will say that our background in taping and wrapping, it carries right over into casting. It's just a different kind of tape, and the difference is it gets rock solid when you're done, and or as you cut off with a piece of scissors, pair of scissors. So.
Mhm. So you sort of talked about the operating room. I know I spent some time with you there while I was at West Virginia Wesleyan in graduate school, and I was only there for a month or so. And definitely seen when you were suturing people up, I was like, I don't think I could ever do that. And it's good to hear that, with time it becomes a little bit more familiar and a little bit easier. I know when we were at the DAT weekend, we just had like a pig's foot, and I was like, Brian made that look a lot easier than than it actually was there. Do you see that? I know you've talked a little bit about West Virginia, still a registration state, and fighting the battle for licensure. Do you see, or do you know of any other athletic trainers working as physician extenders in West Virginia?
There have been some additional. Scott Orthopedics in Huntington, West Virginia, employs some athletic trainers. They actually employed athletic trainers even prior to when Tiger Valley Orthopedics in Elkins brought me on board. Prior to a few years ago, they really weren't using them in roles outside of like serving as a scribe, medical scribe, and doing casting, and then putting them in the field to do outreach at the end of the day. I think they've expanded upon that a little bit and explored some things. I've talked to the one gentleman down there. There still aren't a lot, though.
Mm-hmm.
There's a very small group of people that are using us in that role.
And the last question for you, how do you think your life-work balance is working in this emerging setting compared to when you're working with athletics in the college setting?
Well, it's really tremendously better. Our typical day, runs anywhere, depending on whether you're in the operating room or the office, but runs anywhere from 7:30 or 8 to usually about 4 to 4:30. I have a 20-minute, 25-minute commute. Most days I'm home between 5 and 5:30, whereas I wouldn't even be off the practice field yet. And that's depending on whether it's a fall, spring, or winter sport. So there are aspects that, certainly enjoy of both settings. But as far as family life and that balance, it's certainly better with the consistent hours, no weekends, standard holidays off. So it definitely is evident why more and more folks within our profession have migrated, towards some of these non-traditional settings.
Yeah, that's sort of what I noticed with working with the military too. Is I don't know if I could go back and not have weekends off anymore. You sort of get used to that one.
Yeah, it's tough, and it doesn't necessarily probably have to be that way throughout the traditional settings. I know, the NATA News has done some stories in past years about various places. One Division II college, which I can't think of offhand, and then talked a little bit about the University of North Carolina at Chapel Hill, and how these places have really worked toward getting their staffing levels to a point where folks, if they work more than a 45 or 50-hour week on a busy week, then something's wrong. Part of that is, I think, convincing your athletic departments to get the appropriate levels of staffing. Part of that is convincing them to allow you to implement tiered structures with sports where, you don't necessarily have to be standing at a basketball practice if your office is a minute or two down the hallway. You can be maximizing, spending time with other athlete patients in the clinic doing their rehab while practice is going on, and still have a more than adequate response time, even in the event of some sort of catastrophic injury or illness. So, places that have done that, I'm a very strong believer that athletic training needs to be aligned under student health services. We're a healthcare discipline first and foremost. We got our background under coaching and physical education, and so the model, more schools is that we fall into the athletic department, but that's really a terrible environment for coercion. If the head coach reports to the athletic director and the athletic trainer seemingly reports to the head coach, then, if your star running back doesn't get to play because of a suspected concussion or something else, and the athletic trainer's job is threatened over that, then that should never happen. We should answer to a medical chain of command, not a athletic department chain of command per se. And I think more and more places hopefully are starting to at least recognize that, and better education about concussion and other injuries that we treat. But that's a very real scenario still. And so I think as we get, better aligned with other healthcare entities, that hopefully will, even in the traditional settings, improve our staffing, improve our hours and that work-life balance.
Just to follow up on the outreach thing, do you feel like working with in the orthopedic clinic, you've been able to connect with the community a little bit better than working in the college setting? And if so, what are some things that you've done for the community?
Yeah, it does, create definitely a different opportunity. That was one of the things that, really I was very excited about early on, was the opportunity to reach some underserved populations. Really, our athletes, as you well know from your time at Wesleyan, a staff of 7 or 8 athletic trainers, counting the graduate athletic trainers. Every sport has access to someone to call their athletic trainer. And so those student athletes have really first-class service. Kids at some of the high schools that our office provides orthopedic sports medicine care to, they have an EMT on their sidelines on Friday night providing care. So they don't have somebody to show them what to do as a home exercise program for their ankle sprain. They don't have folks there that have the in-depth background educationally, as well as the experience treating and managing concussions like we do as true athletic trainers. And so it really, there are many kids that the home exercises they got from me were the only rehab program they got, because their insurance would only cover a select number of visits with physical therapy, or would cover no visits with physical therapy. Kids that had post-op ACLs, and at 3 months their insurance said you're cut off. And you and I know, and everybody else that's listening to this is going to know, that that's a critical phase in the ACL rehab process. To tell a kid that they can't go to rehab anymore, you're on your own, what a disservice. That, at least by being able to serve some of those kids, I could oversee and monitor to some extent a home exercise program to get them through some sport-specific functional exercises. Certainly not the equivalent of seeing them 5 days a week in the athletic training facility, but better than them getting turned loose and having no access. So it does allow for that opportunity to hopefully educate and provide some guidance to folks in those underserved areas. It also provides the opportunity to be exposed to even more members of the healthcare team. And I've had conversations about athletic training services with the chief of anesthesia at our facility. I had the opportunity to discuss it with other folks in the OR as things have come up, to try to educate about what it is, what's our background, what do we do, what are we trained, and knowledgeable in, as well as just the physicians that I work with on a daily basis, and the physician assistants. It becomes evident to people quickly that we are the expert on many of those topics. And while we're not the top of the medical chain per se, the ultimate call comes from the physician. So many times in our office, it's, hey, what can we do about this? What can you make them so they can play? What do you think about this brace? Can you give them a home exercise program? To the point where, when football season rolls around, if there's not an athletic trainer in clinic to help the doctor's upset about it, just because that shows the value. So
that's awesome. I'm glad to see that you're doing good things at Taggart Valley. I know when I was there, I knew you were pretty new to it, and I knew you'd do well. And it ties into a lot of things that we've been talking about, especially this semester, about underserved populations, advocacy for the profession, and I know talking to Drew, like, the push for licensure is a big thing, and I think you are a good example of how an athletic trainer can increase patient care exponentially. That's just one athletic trainer in one orthopedic office. So it's good to hear that. And I'll let you have any closing remarks or anything that you would like to add or say before we end the conversation.
No, I think that's really all I have. I appreciate the opportunity to speak with you about it, and as well as everyone that ends up watching this.
All right. Thank you, Brian.
Sure thing.